Hey, Professor Reed, Alexandra here, and today I want to discuss a critical intersection of health policy and clinical practice. While we often celebrate the win of cancer remission, many this victory may also include financial costs that is not really distributed equally across our patient populations of differing heritages. The article I chose is the understanding of racial differences in financial hardship among older adults surviving cancer. In this study, it was published in 2024 by the Official Journal of the American Cancer Society. The study population had 721 survivors, both black and white, and they were age 65 plus, and they also needed to be alive at the time of the study, and they were treated for their cancer at the University of Alabama in Birmingham between the years of 2000 and 2019. I decided on this paper because I wanted to take an evidence-based look at how socioeconomic statuses and heritages intersect to affect health outcomes. This is an interest of mine. All right, let's look at the data. The study found a stark disparity in outcomes among Black survivors who were found to have faced twice the financial hardship of their white survivor counterparts. Specifically, 39% of Black cancer survivors reported financial hardship compared to just 18% of their white counterparts. Additionally, zooming out even more, all heritages, about 40% of all older cancer survivors did report some sort of financial struggle despite having Medicare coverage. To understand why this financial exists between the survivors, I wanted to look at a historical and structural roots, which was also touched upon in the paper. So back in the 1930s, redlining was popular, and this is where HOLC maps segregated neighborhoods based on race and systematically blocked Black families from building generational wealth by diverging investments out of these neighborhoods. This created the generational income gap that still persists today. We can see this because in the study, 65% of Black cancer survivors earned less than $50,000, while only 34% of white cancer survivors fell into the same bracket. We also see this in neighborhood deprivation scores, with Black survivors living in areas with a median area deprivation index, an ADI of 93, compared to 55 for white survivors. The higher the number, the less desirable or less healthy of a neighborhood is how we can look at that. Ultimately, even when cancer diagnoses and the treatments were similar or even the same in some cases, the financial burden had a diversion between the two groups. Our important takeaway is from this research that income and neighborhood deprivation, both are which downstream effects of structural racism, explained about 35% of why Black and white disparity financial hardships of cancer survivorship exist. Moving on, so what is our role? What is our role as providers and for me as a future clinician? First, we must screen routinely our patients for social determinants of health. We need to ask every patient about financial concerns, and when they come up, we need to normalize them in conversations, and we shouldn't make assumptions based on appearance. Second, we want to look beyond our patients' medical charts, maybe take a look at housing or income or the various neighborhoods in our own communities, and this might give us a better idea and predictive value of a patient's ability to adhere to a treatment plan than just looking at some lab scores. Third, we need to treat social resources as part of our medicine workup. Financial navigation and copay assistance and social work are all essential parts of the care plan, and we need to include them initially and not as just an afterthought. Finally, we must develop our own structural literacy and understanding of the history of our nation, and we need to be informed about redlining and things that have influenced our current patient populations. So while redlining may have ended in 1968, its downstream effects still are infecting the patients that we see sitting in our exam rooms today. All right, so as I conclude, I want to leave you with this. Sometimes the most important part of a visit isn't in the notes. Every patient is the result of decades of history, and it is our job as clinicians to show up knowing that history so we can better serve our patients' future. Hope you enjoyed this little summary of my paper and my article, and can't wait to discuss it in class tomorrow. All right, thank you, Dr. Reed.